Hello, everyone. Welcome to the All Out Coach podcast. My name is Tim Mikhelishvili. I'm your host, also CEO and co-founder of Pharma, performance analytics agency for life sciences that helps medical organizations quantify their direct business impact on the healthcare community, patients and providers, and their colleagues. Today, I am speaking to Rob Braun, who's had decades of leadership experience in medical education, in life sciences and pharmaceutical, biotech. He has been a leader on the commercial side in advertising as well, and continuing medical education. He's president of Global Learning Collaborative, Omnia Education, Prova Education, Medtelligence, and AGILE specialties, with experience in oncology, and also some recognized medical education brands that you will all probably know, such as Mesdcape, WebMD, where he served as executive director. And so today we're going to talk about the importance of teaching and testing in medical education in our digital environment in which we all live today. So, Rob, it's a pleasure to have you here at All Out Coach. Would you like to start by telling us a little bit about your current role and Omnia Education, Global Learning Collaborative? What does that mean?
Yeah, sure. Thanks, Tim. Nice to be here. Thanks for having me. So I've been overseeing Global Learning Collaborative for since around 2018. And so we have a couple divisions that are dedicated to certain fields and specialties. So our Omnia division focuses exclusively on women's health. And then we have Prova Education, which is multi-specialty. So oncology is a big one for us, neurology, gastroderm. And then we actually have Medtelligence, which is exclusive on cardiovascular medicine, cardiorenal, cardiometabolics. And then AGILE is another division we have that really we do the OUS, so education outside the United States.
So how does a podcast really differentiate itself amongst so many different channels in terms of ultimately improving quality of care?
Yeah.
Can we start there?
Yeah, so that's a good one. Education is certainly many different formats that we develop and work on, and podcasts have been a hot one the last couple of years, ever since I got here. And so we do live meetings, we do satellite symposia, we do traditional digital programs, video-based programs, didactic, case-based learning, and some interactive type programs. But the one thing that podcasts I think have that some of these other device or formats don't have is convenience and flexibility. Today's practitioner is really busier than ever, right? And so, maybe they just don't have the time to read that journal article or that textbook or watch that video program. But they have time when they're commuting to and from the office. Perhaps there was a patient experience, and they now have a question on their mind about how to diagnose, treat, or manage a disease. They can go find a podcast and listen to it on their way home and they commute, or when they're doing other daily activities and tasks. So I think one of the nice things about podcasts is it offers a lot of convenience and flexibilities of different ways you can watch them and consume them, from your mobile device to your tablet. The other thing I think that podcasts do really, really well that we recommend, and in our early days we did one or two more didactic-based podcasts, is keep them interview-based or discussion-based. I think, when you go to a satellite symposia, we see a lot of didactic lectures. I think podcasts really get delivered when it's conversations and allowing, faculty experts to contextualize evidence or contextualize patient cases, scenarios. How do you manage and treat this patient? And so I think that becomes a little bit entertaining as well as getting educated.
Yeah, so many people think of podcasts as audio alone. Your approach terms the podcast as podcast in motion. Let's dig into what makes your particular approach to podcasts one that shows that it's dynamic, helps people not just listen, but also interpret and apply that information somehow.
One of the things that our company does really, really well is, I have a team of animators. And, so when we started looking at the growth of podcasts, and I started looking at the marketplace about how people were accessing podcasts, and all these publishers, like we're a publisher, we can put information out into the digital environment. But what I was seeing was a lot of sound bars on people's websites. So certainly you can consume consume podcasts on Spotify, iTunes, Google Podcasts, and a great audio experience and wide distribution. But we on the CME side send out a lot of emails to get clinicians to engage in our content. So it doesn't mean that they're going to be on a mobile device. They may open it up and they're sitting at their laptop like you and I are sitting here on big screens.
Mm-hmm.
So looking at a soundbar may not be the best user experience. So what we decided was, why don't we add a little bit of supplemental animation to that, so that if we do get that user on the desktop, we have a kind of a unique user experience. They're not just looking at a soundbar. So it'll be an audio experience. On the right-hand side, you're seeing a laptop there. And so as faculty speak to that important teaching point, we'll make that animation appear so you get a visual cue and an auditory cue. And then if you're looking at it on your mobile device, you got a really, really nice looking user experience. Now we don't have animation all the time. Sometimes it's just audio. Sometimes they're just talking. There's no need to animate anything. So it's just a traditional audio. But it allows us to add tables, charts, and charts. Oncology is such a data-centric market, right? So I think to see the data as faculty verbally say is a nice entry point or differentiation. So I think when you consume our program on a Spotify app, you're just getting that audio version. What we use is ReachMD. ReachMD was born out of Radio Legacy, so it has a great environment. But they have the platform that we could kind of serve outcomes instruments too, which will allow us to measure effectiveness of the podcast.
Yeah, and I definitely want to speak about that as well, because in my review of medical education, where I actually started my career at Aventis, which then became Sanofi, was acquired by Sanofi, I've seen data that shows that most of the information, most of the social media delivered medical education metrics, in particular KPIs, they indicate that they are accepted. A lot of physicians are using them, clinicians early in their training, also those who are seasoned. However, there is somewhat of a gap in the outcomes on behavior, and I realize how difficult it is. And I remember those times myself to organize a program, then distribute the surveys for evaluation surveys, where you may get some responses. Some physicians will tell you, okay, I intend to change my behavior, right? What are some approaches to improving that direct impact on KPIs, on outcomes, and how can podcasts address these gaps?
Yeah, good questions. And I think sometimes it's where the content is consumed, right? So when you're consuming on Facebook or even Twitter and things like that, there might be a bit more challenges to serving some sort of the outcomes instruments that we like to do in medical education, right? So that education worked. With podcasting, a lot of us are using those big podcast channels to broaden our reach and distribution, right? But you really can't serve that outcomes instrument on Spotify or Apple iTunes, right? You're not going to get a pretest or a post-intervention survey. So I think one of the benefits and what industry wants to look if they're going to be funding podcasts is they want to align with somebody that's credible as well, right? So these publishing companies, journals, maybe universities, things like that. So somewhere where there's additional outlets where that content can be consumed, where you can actually use some of their platforms to serve a pre-intervention survey and a post-intervention assessment. And so we've been doing that, and I said that's why I like using the ReachMD platform. Is they have all these different network channels to distribute the content, but they actually have the embedded ecosystem to allow you to serve CME certificates, as well as pre-test questions, post-test questions, case-based questions, and we can target specialties too. So we can actually target relevant oncologists or neurologists, and depending on what we have. So to have that partner that allows you to drive an audience is going to be really important, and not be solely reliant on social. Because social can add to scale. We use social very much for audience generation capabilities. So we'll use social to enhance and drive people back to the learning center where we can, to deploy the content as well as the outcomes instrument.
I see. Okay. Yeah. So, and the attendance from the perspective of engagement, maybe we can start with just engagement. And what are some trends that you've seen in engagement among particular types of attendees, physicians, through your programs?
Yeah. Well, so I sent over a slide to you that we're looking at right now. So this is an example of an oncology one in bladder cancer. And again, what we were able to do was use our partner in ReachMD to kind of really set out some targeted campaigns to relevant audiences. It was also, distributed on those traditional podcast outlets as well. But what we were able to do was do a couple of things. One was look at the target audience, right? So we wanted to reach, oncologists, urologists, and pathologists in particular. So you can see we did a really great job with 4,500 total learners. We got a vast amount were physicians. And then at the oncology specialty, 1,800 or so oncologists actually engaged in it, and 900 or nearly 1,000 urologists. But the nice thing that we looked at was how long did they stay in the program. And what we found is, if it's really relevant, they're going to stay, right? So if we get somebody to stay 50% or longer into a program, then we're doing a pretty good job. If we lose somebody here in this example, if we lost somebody in the first 25% of the program, that was about 14% of the learners. But ReachMD started a little statistics that if you stay 50% or greater, they would consider that a committed type learner. So what we found with our podcast is very high engagement. So 80%, 90% staying 50% or more, with the vast majority staying 75% or longer. Now, the other secret sauce to that is brevity. So we don't do really long programs. We tend to focus on 2 learning objectives, maybe 3, and we tighten up the content to be about a 15-minute or so conversation or discussion. So we don't go really back into the early stages of this disease, and that we'll look at the goals of the program and design it so that we can get the content in a shorter amount of time. And that's when we're seeing greater completion rates.
I see. Okay. So that's the completion. Now, Dr. Ian Lang, a physician in 1991, he said that teaching without testing is like cooking without tasting, reading without writing. And I think you really feature the importance and the significance of testing, and doing it very deliberately in a serial manner, like in a modular fashion, in bite-sized kind of podcast that you mentioned. Now, can you talk a little bit about the outcomes, actually measuring clinical outcomes?
Yeah, great.
From your programs.
As ReachMD and Medscape and Helio, or some of these other big platforms, are publishers, they might be able to serve these pre-test, post-test instruments, right? And again, I'll just say it again. We're not going to get the surveys on Apple Podcasts or Google Podcasts. So you got to have that other channel so you can measure it and use those Spotify's to have that extra content consumption. There's nothing wrong with consuming content, right? So in this example here, this was a different bladder cancer one that we did a little bit ago, but we're trying to educate our learners about, does everybody need to be tested for biomarkers to use certain therapeutics in bladder cancer? So we posed a pre-intervention question, and then we asked the same question again following the podcast. And so you can see at pre-intervention, 23% were correct. Post the education, we had a 57% improvement in that knowledge. So we were able to transfer about the importance of testing, and if everyone needs to be tested, from an individual treatment strategy in bladder cancer. So great improvement, showed education worked, but it also uncovered that maybe we didn't hit everybody, or that wasn't received completely. So there's about a 40% gap So we might recommend continued education on treatment strategies and interventions in bladder cancer, and who, when, and why.
Now, is there a particular range of time after the program where you tend to test most often, and do you repeat those same tests maybe later on down the line? Can you just go into a little bit of detail on the timing of the
Yeah,
tests?
So most of our survey instruments are kind of shown to the learner or made available immediately following
Immediately.
the
Oh,
content. And
okay.
so that's when most of our pre-test, post-test occurs. If the initiative warrants it, we've also kind of looked at maybe looking at a reinforcement type
Right.
program, or maybe we'll repeat some of those top learning objectives, so we can remind them of, hey, this is what you should have learned. These were the hot buttons from that program, and we might be able to include a survey instrument in that as well. What we found is it's pretty difficult to do some of those extended follow-up surveys to get a significant number of people to participate. I think that's been a challenge to all of us as CME providers. Is these follow-up surveys that we do, it's hard to re-engage them once you're 3-4 weeks down the road, to re-engage them in that survey instrument. So your ends might be a little bit lower.
Okay. And how do you incentivize them to respond? Do you have high response rates?
Yeah. So sometimes, what you might do is, we've done is kind of what we call a certified second program. And so similar agenda, faculty, and learning objectives, and offer, again, CME credits, and that pre-test could actually serve as its follow-up. Or sometimes we'll offer a gift card, or an Amazon or Starbucks gift card to take a survey, and just offer a survey to them to enhance participation rates.
So you have a vast experience in the world of medical education, right? So I want to ask you, what are some of the latest trends? How has medical education and its quality really changed over the past few years, let's say, over the past decade, let's say? How does that relate to the preferences? Are the preferences of those who attend CME programs today, are they changing as well? And you touched on some of them, but
I think there's a couple of hot buttons that are kind of out there right now. So let's start with Brevi, right? COVID forced everybody to go digital, right? So everybody had to kind of start doing digital programming, digital interventions, online programming, and a lot of us are built still of that live meeting setting where we're trying to cover an hours-long program in an agenda, and then put it online and expect people to watch an hour-long program. And that's a different experience when you're sitting in a live setting versus somebody at their computer self-directing them to the content. So COVID taught us a lot of things. It taught us, how do you do digital, and there's some people that do really, really good job with it, and then there are others that just take that live and try to do it. So lessons learned, and we got to get better there. But brevity, micro learning, right? So what we are seeing, so we've done 15-minute short 2-active programs, but now we've actually moved towards even micro learning courses where we can maybe look at a topic and segment it down into one learning objectives, one question before the micro course, one question at the end, highly focused. And say maybe we're doing something on diabetes, we could do something on diagnosis, treatment, manage, case, peer perspectives, patient commentary, and that would be just a collection of 5-minute episodes, and we can market those 5-minute episodes to that audience. So micro learning and short form education can work. And then you could do an outcomes instrument where you don't have to burden the user with so many questions either, right? That's the nice thing is, you're asking them to ask one question,
right?
And before and after. That's easy enough to do. So what we're seeing is really high participation, and we're seeing really good ends in our survey instruments with this micro course. The other thing that I'm running across a little bit more and more is some small group learning, and some return to live. Obviously, with post-pandemic, we're seeing more return to live. But small group learning is something that we've seen. We've partnered with real CME and done some gather ed type programs where they get a moderator and they lead a small group through some educational interventions, allow for some self-study. And then also in the live setting, there's potential to get some small groups together and do some more regional type of education. Grand rounds, I think, have returned with a vengeance. In oncology, we're seeing a lot more grand rounds coming back and an appetite for that.
Okay. One question I do have to ask you, I think that's very relevant, is what makes continuing medical education that's accredited important and critical today from all other types of sources of education that are out there on TikTok? And now I'm hearing that a lot of physicians are, educating via 1 minute quick, sound bites, right? Even platforms such as TikTok. What's your personal position on making sure that the information is accredited and its quality is accurate?
Yeah. I think CME, the hallmark of CME, right, is its independence.
Right.
It's fair balance. It's evidence-based. I've done a lot of presentations to industry on the value of CME, and when I meet folks, very high up on the food chain, they think it's all about getting credits, and most doctors in the digital environment don't get credits. They really participate in CME because they know it's going to be evidence-based and fair balanced, and so it's quality. So there's a hallmark of CME might carry a badge of quality, a badge of credibility, and evidence-based, and free of influence, right? It doesn't mean that non-accredited education doesn't work. I think we all are driven by a question we have, a topic of interest,
Sure.
and sometimes, if we're on YouTube or something like that, well, how long is this video? Am I going to have to set this for 20 minutes, or is this like a 3-minute type of thing, and I can get my soundbite? So there's needs for both. I just think your question as it relates to CME, I just think that CME carries a little bit of that hallmark of quality and credibility with the physician community, or clinicians, I guess, all clinicians.
Okay. Well, I'm really grateful for being introduced to you by another leader in medical education, Patty Jesak. Yeah. And I want to ask you where the listeners can find some of your programs and some of the innovative work that you're doing, and that systematic approach to education. What is the website? Where can physicians who are in the network, or some of the listeners to All Out Coach, healthcare professionals, and not only, maybe others as well. Yeah. What is the website?
Sure. So we host all of our programs on each medical education division's website. So omniaeducation.com, if you have interest in women's health. Prova Education.com would be, oncology and multi-specialty. Medtelligence.net would be our cardiology and cardiovascular education. And then we also distribute on a lot of our activities for broader reach and more, specialized reach is on reachmd.com. And so there you'd have to kind of circ out, your specialty, and you'll find some of our programs on the mix of other med ed companies that are using ReachMD.
And provaeducation.com is the second one, I believe, correct?
Right. And
I'm going to just I'm going to also add that one. And that one focuses on oncology, you said.
The oncology, gastro, neuro, derm, it's multi-specialty. And then cardiovascular medicine would be our Medtelligence.net, MED, Medtelligence.net.
Medtelligence.net. Well, the slogan here at All Out Coach is stretch yourself, lift others. And one of the ways to do that, I think, starts with education, right? So very often we are so focused on our work, on our, routine or the daily routine, that we forget to educate ourselves. And in fact, there's data to show that the years of experience, even in healthcare and medicine, have a reverse relationship with the quality of healthcare. And that's where I think education, independent, non-independent education comes in. And those are the times that I always look forward to. I do that on LinkedIn. I don't do that enough anymore, but these opportunities to talk to people like you, leaders like you in education, are an educational opportunity for me as well and for our listeners. So Well, great. Well, I want to leave you with the last words here and any final message for those who are looking to learn in this environment in which there are probably more opportunities to communicate and to learn than ever before. What are some parting words from you?
Yeah, I guess. Well, thanks for having me. I think this is my first podcast, so.
Oh, really? Wow.
Anyway, I
You're
would
great.
say, don't be afraid to try something new. I think we're a fun time period where digital is really entrenched. You can do some really fun, creative things, and blending audio, video, and text to deliver some novel formats, and learn from your mistakes. Right. So if something didn't work, you certainly can learn from that and pivot along the way. But I'm a big fan of just trying things new and being really creative.
Yeah.
Great.
Yeah. Thank
Great.
you very much.
All right, Tim. Really enjoyed it. Thanks so much.